Okay, today we are going to start working on the nursing process and care plan development. This is the first step, which is clustering data. The first thing that you need to do, I'm going to give you a case study that I've used now for a couple of years, and it really works well because it's loaded with data. You're going to read it and underline what data you think is important. After you guys finish doing that, we're going to take each piece of data and we're going to figure out where in the basic human needs model it goes. Okay? That's the first step whenever you take care of a patient and you're going to do a care plan that you need to accomplish. Okay? So take one of these, pass them down, and whatever extras, just throw them in the middle. I'll give you about 3 minutes to read those over before we start working on the board. Can I just ask you one more question, though? Is if we say that our patient had surgery, if your patient says, Lori, I had surgery, what kind of data is that? Objective or subjective data? If I went into the chart and I verified that that surgery had occurred, then it becomes objective. Okay, just so that you differentiate. Keep in the back of your mind when you're going through this case study which pieces of data are objective and which pieces of data are subjective, because next week we'll deal with that. Okay? All right, read your case study. Just throw them in the middle. Okay, everyone ready? Okay. Next thing I want you to do is I want you to take your 2 pieces of paper and just take them apart so that you've got now 2. You've got the case study and then next to it your clustering sheet. We're going to cluster our data, pieces of data, into whichever basic human need it affects. I'm going to do the first piece of data to show you how it's done. Flip your papers over so you can see the case study. Yeah, the back doesn't matter. Okay? So I'm going to take the first piece of data. Each group will have, as I told you, a little bit different take on the data. I'm going to ask you a lot of questions. I'm going to ask you a lot of whys. I want you to try to figure out why you're putting it into that basic human need, why that piece of data is affecting that basic human need. And sometimes you can do that easily, and sometimes you go, I know it goes there, Lori, but I'm not quite sure why I'm putting it there. And for the majority of the time you're right where it goes, but I'm going to help you to try to figure out why you're putting it there. And sometimes it's because you just don't have enough knowledge yet, because you're just starting the program. So I'll try to give you as much knowledge as I can give you during these, and hopefully you'll retain some of it. So the first piece of data that I'm going to do is, this is the 75-year-old. And I know from experience that if you have a patient who's over 65, they are prone to fall. So the first basic human need that age affects at 75 years old is prevention from harm. So I'm going to stick that 75 years old in prevention from harm. Okay? Now, when we look at age affecting basic human needs, it doesn't only affect one basic human need. Data can overlap and go into multiple basic human needs. So I know that a patient or a person who reaches the age of 75, normal aging process can cause some elimination issues such as constipation. So 75 years old can also affect elimination, so we're going to plop it into elimination. Okay? Everyone with me? Okay, now it's your turn. Let's take a piece of data and figure out where it goes. Some groups like to just grab a piece of data anywhere in the case study. Others really like to go sequentially. It's up to you guys as a group which way you want to go. If you want to go sequentially or if you want to go randomly. I call it an outline mind and a paragraph mind. Sequentially. Okay, so what's our next piece of data?
Functioning independently.
Yeah.
Okay, can we call that active lifestyle, independent active lifestyle when we put it up here? Is that okay with everybody?
Yeah.
So what basic human need is the past history of an active lifestyle going to affect?
Activity.
Sure, activity. Why is it going to affect activity?
Because that's how his activity was functioning okay then. He's independent.
Yeah, it's going to say where he was at before he came into the hospital or the extended care facility or wherever your patient is coming into. So active independent lifestyle or independent active lifestyle, however you want to put it, is up there in activity. Where else is that going to, what other basic human need might that affect?
The psychosocial.
Self-esteem.
Love and self-esteem. When you're looking at these, don't look at the middle column that just breaks it into big categories, but look at the left-hand column. Love and self-esteem. Why is it going to affect love and self-esteem?
Because
That affects the self-esteem.
that's the way he was.
He was independent, not he was independent person.
He has a lot of confidence about himself.
Okay, it's going to affect it two different ways is what I'm hearing from you. Because he was independent and active lifestyle before he came in, this new problem could affect him negatively, I'm hearing, could cause some depression. But what about, let's look at the flip side of that. Could it affect him positively because he wants to get where he was? Or, so it can affect, it's going to affect love and self-esteem, but I want you to think about it affecting him two different ways, depending on who your patient is. So, independent, active lifestyle. Okay. Anywhere else we're going? I don't really. Anyone else have a case for any other basic human need that they want to put that under? No? I think we've got both places. Okay, what's our next piece of data?
Is it, sorry, the first one, is it usually two, only like?
Can be, no.
As many as you want?
As many as you need, as many as it takes. As many basic human needs as that piece of data is going to affect. So it might be multiple, it might be only one. Okay?
He lives with his wife.
A 53-year-old wife and 3 nearby grandchildren. So
Doesn't he have the wife of 53 years, not the 53-year-old wife?
53. Oh! I thought she was 53. So say she could take care of him.
Yeah, really. Okay, so wife of 53 years and children and grandchildren.
Nearby.
So where are we going to drop that?
Love and self-esteem.
Okay, yes, definitely love and self-esteem. So he's
Family
got a
support.
wife, children, and grandchildren. Yes, ma'am.
Question.
Yep.
On the last point, we said that he was living independently with his wife for 53 years, and they have a very active lifestyle.
Right.
Could that go under sexuality? I mean, they can still be intimate. We don't know.
Yeah, we can put the wife and children. Yeah, they go, definitely.
No,
The independent.
yeah.
Okay, yeah, we can put all those things under sexuality. You're right. We can put wife times 53 years. Not the 53-year-old part. Children and grandchildren, and his independence, independent and active.
How would children have to do with
Defines
sexuality?
him, defining him.
Comfort, support.
Yeah. Okay. What's our next little tidbit?
Active
Data.
lifestyle.
We have done the active lifestyle. We did
Lifestyle.
independent active lifestyle. We can lump
Okay.
that together.
He is admitted.
For a short term.
Okay, that kind of goes without saying because that's where he is.
His
Okay.
career.
Okay, you want to
Move on to next.
Let's take the past medical history.
Yeah.
Okay? Why don't, now I'm going to just plop it right here in the middle. Don't you guys write it down and then we'll divvy it up to where it goes. So why don't you just read it off to me and I'll write it down.
CAD within.
Does anyone know what CAD is?
Coronary
That's
artery
what I was going to disease, yeah.
And he had an angioplasty.
Plasty
So
in
CAD
1990.
with an angioplasty.
Yeah.
The C with the line over it means with. Okay, what else does he have?
Hypertension.
Hypertension, HTN, you'll see that abbreviated as. Go ahead.
Yeah. Diabetes. Yeah.
Diabetes, IDDM.
Polyps.
Polyps. What else?
That's it.
He's a
He smoked for 2
Smoker.
pack cigarettes for 25 years.
2 packs per day
Day
times 25 years.
cardiovascular.
And he has a
Suffering CVA.
CVA. Which CVA do you have, a right or a left?
Didn't say.
Okay, well, if
It's
he has...
right-sided weakness,
Right
so
side.
it's a left.
Left
So it's
side.
a left.
The left.
Why is
The
that?
left
always the
affects the
opposite.
right and right affects the left.
Because our nerves cross?
Cross in the brain.
Okay, so if you have a left CVA, you're going to have right-sided symptoms. So he had a left CVA. Okay, so let's plop these in where they need to go. Cerebral vascular accident.
Stroke.
Stroke. Yeah, that's okay. No, that's what you guys need to do. You need to ask those kind of things. You're not expected to know that at this point.
You know, it was a left-sided CVA because it says he has a right-sided weakness.
Yes. Okay, so let's take coronary artery disease. Where are we going with it?
It's a-
Oxygen.
Perfusion.
Sure.
Oh, yeah.
Perfusion kind of issue. Okay, so PMH, I'm putting down coronary artery disease with angio. Okay, so we're all set with that. Let me just erase it from our big list here. Hypertension.
Fluids and nutrition? No?
Well, why?
Oxygen.
hypertension.
Give it a shot.
Because if you're hyper, you don't need a bunch of fluid. If you're hyper, if you have a bunch of fluid intake, you need. If you're hypertension, that means you have high blood pressure, so you don't want to pump fluids into them.
His diet.
I guess that's kind of a stretch.
Okay.
Because we don't have that information. But we do have a diet that's specialized for the hypertension. That's really good putting those 2 and 2 together. So can we just put that down here? Because we'll do the diet all together as one.
Okay.
But let me put it down here in the middle. He's on that 1,800 calorie, low sodium, low cholesterol,
Heart healthy.
thick liquids. And we'll deal with all that. Let's
Together.
just deal with all that, yeah,
Okay.
after the fact. Let's, the hypertension, I heard
hypertension.
oxygen, and that's absolutely
Yeah.
right. Can you tell me something, though, when you have someone who's hypertensive, do you give medications for it?
You do have
could,
hypertensive
There are
medication.
some medications.
Yeah.
Yes, most of the time when people have, I think it's pretty, I don't think it's a pretty much of a stretch to say that if he has a history of hypertension, he's going to be treated with something. Now, if you were in the hospital, you would have that medication list and we would be able to plop it into our clustering. But we don't have that. So just so that I get you guys thinking, if you're on an antihypertensive and you have a blood pressure that drops, what can happen when you sit up?
Get dizzy.
You can get dizzy, and then what can happen?
Pass out.
So where would we plop that?
Prevention from harm.
Yes, absolutely. So we can put our hypertension in there, because then if our blood pressure goes up, we can also have some symptoms of dizziness. So I don't think it's too much of a stretch, even though we don't have the medications, that we put it into prevention from harm. Okay? So our hypertension's taken care of. What about our diabetes?
Foods and nutrition.
Fluids and nutrition, absolutely right. Past medical history, IDDM. And we'll deal with the diet after in a little while. What about our polyps? Which is it? Did anyone know what a polyps is?
Yeah, it's like little
Precancerous growths in the colon. They take them out. Is it really affecting anything though? But we've got to put it somewhere. Elimination, because we'll watch for some change, because it could potentially have an effect if they regrow. But you know, it's not there. They were taken out. They were taken care of. But we can put them in there. We wouldn't build a problem around a polyp because it's something that's been taken care of. We wouldn't build a nursing diagnosis around that. But it's information that you've got, and it's got to go somewhere. So polyp. I'll just put past medical history. Okay, smoker, 2 packs per day for 25 years.
Oxygen.
Yes, oxygen. You guys are good. Now, is that subjective or objective?
Subjective.
Now, if it is definitely subjective data, if he says he took 2 packs a day for 25 years, do we necessarily believe that as,
No, it's probably more than that.
Yeah.
They always tell
Yeah.
us more than that.
yeah. Smokers
always
tend
more.
to decrease things a little bit. Kind of the nature of the beast. Okay, now, our CVA, our cerebral vascular accident. Cerebral vascular accident is caused by either a clot in your brain or a bleed in your brain. So either way, circulation's not going to get past that and go where it needs to go.
Prevention from harm.
Oxygen. Why prevention from harm?
Because usually they don't understand, they become disoriented.
But do we have that data?
No,
No.
they're usually one-sided paralyzed.
And does this guy have that?
Yes.
Instead of week-
We have right-sided weakness?
Yep.
So why don't we deal with the right-sided weakness right now,
Okay.
while we're thinking in that line? So where are we going to put this right-sided weakness?
Prevention from harm.
Why prevention from harm?
Because
Because it's going to be,
He might fall, absolutely. I'm going to put it as RSW. Okay, that's the way I'm going
right-sided
to
weakness.
abbreviate, because we're going to be writing it in a lot of places. So RSW is our best bet. You don't have to raise your
Go
hand.
under activity as well,
Yeah, why activity?
because he's gonna have less, he'll probably won't be able to stand up or something on his own.
Oh, definitely. Yes, you're absolutely right. Right-sided weakness. Where else is it going to go? Prevention from harm, we put it there already.
Pain?
Rest and sleep,
Rest and sleep, why? I'll deal with pain in a minute.
because you're going to have to turn him, help him turn at night.
And he might be like an abdominal sleeper or a side sleeper.
Right.
You're definitely right. Pain. Do we have any data that just right-sided weakness affects the basic human need of pain?
no.
I don't really think we do have that. There's other things that we'll put in there, but
Sexuality,
why?
can't do nothing.
You're right. It can also it also affects how he feels of himself as a man.
To love is love and esteem.
Yeah. See, you're thinking, you're getting it. Right-sided weakness. Where else is it going to go?
Would it go under fluid nutrition, because we'll have to help him to his nourishments and fluids?
I know
Drink
that if I
more.
had paralysis of my right side and I was eating with my left hand, that I would drop everything all over myself. Yeah. Okay, so we're putting it right-sided weakness over here. Why asepsis?
Hygiene. Yeah.
Yeah, you're right. Okay, anywhere else we can go here? Is he moving around the way that he did before he came in?
No.
Is he- so what else happens? Why? Because he's not.
Right.
People who are in bed tend to have decrease in elimination, so yes. Besides that, he's not able to get up the way that he was before. Okay, next. Can we deal with the diet here, since it's here in my
Yeah.
middle board? I know it's probably not the next thing in a row, but it's in my middle section. Okay, so where are we going to put his diet?
Fluid
Fluid and
nutrition,
nutrition.
elimination.
1800 ADA, or let's see, low sodium, low cholesterol, thick liquids. Why elimination?
Because what goes in has to come out.
I know. Let's look at just a piece of that, though. Does the 1800 calorie low sodium, low cholesterol really affect elimination?
The eight, no.
1800.
Does that affect elimination, though?
Maybe the thick liquids,
Why the thick liquids?
because you have to thicken the liquids and that produces elimination.
Who in here has tasted
Thicken.
liquids that have a thickening agent? So are you going to be drinking the amount of fluid
No.
that they drank before they come in?
No.
They came in? No, they don't like it at all. So the piece that should go under elimination is not the diet, but the thickened liquids. Okay, everyone with me? Is that okay?
Now, would it be prevention from harm, because he on a thick liquid means that he has choking, he can choke, so
We could aspirate.
aspirate, yeah.
So we can put aspiration precautions
Right.
and the thick liquids. kind of jumping the gun, but that's okay.
Okay.
Anywhere else we can put that thick liquid? How do you think that he would feel
Love and
about drinking his
self-esteem.
morning coffee with a spoon?
Spoon.
Self-esteem.
Self-esteem.
Love and self-esteem, yeah. Anywhere else? We all set with that? Okay, so I can get rid of this in the center here. All right, what's our next piece of data?
Splint.
Well, we did the right-sided weakness.
The splint.
Splint. Okay. I'm going to put this down as splint and sling. I'm going to put like S/S. When you're doing your clustering in the clinical unit, you would write exactly what that splint is going to and that sling is on. But for our purposes, we're not going to write that all out. We're just going to put it as a category, splint and sling together. Okay? Where's that going to go?
Love and
Activity.
Activity, yeah, absolutely, because that's going to affect how he's moving. So I'm doing S/S. And we'll remember that when we go to our next step next week.
Okay, he has a split and
And
a
a
sling.
sling.
So
Love and
elimination too, because he can't really move. He need help.
Mm-hmm. Yep.
Foods and nutrition,
Why?
because he need assistance with eating.
Yeah.
Prevention from harm,
Why?
because he could fall.
Why are we putting that splint, or that, actually, let's take them one at a time. Why are we putting the sling on his arm, on his right arm?
Because it's weakness.
So what's that sling doing?
It's holding the arm, stabilizing it.
Right, so what doesn't happen?
Because it's so over and need to make that weak,
No.
make them like tilt to the side. And
That, yes. Also, when you're getting him out of bed, seen it happen. No sling on, arm got stuck in the wheelchair mechanisms, big laceration on the arm. Elderly people have very fragile skin. I mean, it took a long time to heal. So the splint is another story. If you have a splint on the leg, the lower leg, it's to hold that ankle so that you get that support that you need in that ankle after you have that weakness or paralysis. Okay? So they both go there for those reasons. Anything else? Anywhere else?
What about rest and sleep?
Why rest and sleep?
Because he has a paralysis. That slump is there. I would probably want to put something there to support it.
How long is it on for, though?
It's only while he's out of bed. OB.
But no, you're not
Split
wrong.
on his
I'm
But
not,
I'm still thinking that
when
he
he's in
needed-
that chair, is he going to be actually able to sleep or take a nap with that stuff on? I think you could make a case that it's going to, but not because of nighttime, but because of during the day.
All right.
Okay, anywhere else? It's not going to affect oxygen.
It won't affect love and self-esteem.
Will it?
Yeah, I think
Yeah.
Yeah, is he going to feel really, how's he
See
going
me
to feel?
come in,
Yeah.
can give him a hug.
Right. Asepsis. What about that?
Oh, I'm sorry.
Can't
Can
wash
you
his
go
hands
anywhere
properly.
where there's
Sweat.
Right side of
Oh,
the
yeah.
listed?
For different reasons, but sure,
Yeah, but
there's a
but-
lot of places, yeah.
Like in sepsis, because he could sweat and stuff and it
Sepsis,
gets all
yeah.
stinky.
Yeah, and the
Moist.
splint.
Yep.
Splint. So I think the splint goes there, but does
Right.
the sling?
No.
Yeah. So let's break that one out and put splint. Okay, what's our next piece of data?
Just a question. For
Yep.
pain and avoidance, because I know when I had a spling, I had it this way. It killed my shoulder. Here, it rubs against here, and then not only that, my shoulder got weak under that. I had to do my ROMs to move it around. If I didn't do that, it got real tense under here, and I couldn't like move my muscles. But it
could
also
make-
hurts because it's heavy.
You could make a case for it. What does the group want to do? Do we have enough data to support it from your life experiences?
Well, he had it on for a while because his sacral area of his left elbow had gotten reddened. So
Sacral area is in the bottom.
Oh, sacral.
Elbows
that's
on
right.
the.
Okay. You're
Well,
right.
can we take skin breakdown then and put skin breakdown in
No.
pain
Yeah,
avoidance,
yeah.
not the splint and sling? 'Cause
Yeah.
they could have caused that, so now we've got the.
I meant left elbow. Yeah.
Okay,
Said the
the
thing.
same thing with the skin breakdown. You're going to have to put exactly the areas of breakdown. I'm just going to put skin breakdown for our purposes, but when you're in clinical, you would write exactly where your breakdown was and what kind of breakdown it is. Okay, does everyone agree with that? But I'm just going to put for us skin breakdown. And I'm going to start with it in pain. Anywhere else?
Sepsis.
That's sepsis.
Why sepsis?
Risk for infection. Infection.
Well, we can't keep skin sterile, but
You get an infection.
yeah. Yeah. To avoid infection, where else is that one going to go? Right, definitely. And we don't want any further breakdown. Right? Anywhere else are we going there? What are we
Rest,
going
when you rest and sleep.
to... Why?
It's painful to break down the tears in your bottom. You can't lay on your sacral area because your bottom's hurting.
So what are we going to have to do for our patient?
Turn them.
Turn
How often?
Every
2 hours.
Is that going to affect our sleep?
Yes.
Anywhere else that it's going to affect?
Elimination,
Why?
because when you eliminate, it's gonna burn.
If we're
Skin
incontinent?
breakdown.
Yeah,
If we're
he's incontinent, it's
incontinent,
going to
right.
burn.
So it's the urinary
Urinary
incontinence that
incontinence,
is the
yeah.
problem, not necessarily the skin
Okay.
breakdown?
Yeah.
So can we can I put it up here?
Put it
And
there.
can,
Yeah.
can we come back to it?
Okay.
I'm just going to put it in my center aisle there, and we'll come back to it. Well, okay, skin breakdown. Anywhere else we're going to affect? I see one more spot. I see actually 2 more spots.
What about when you break down, don't you always use something, an ointment or something to help that area, to keep it from, prevent it from?
Preventing other areas.
Right.
But we don't have that. If
Okay.
you had, like, we don't have any medications in there.
Mm.
Anytime you had meds, you would plot
Okay.
them in your basic human needs. But we don't have those, so we won't plot what
Mhm.
we don't have.
All right.
Okay, but you would definitely.
Sexuality.
How about, yeah, how about love and self-esteem?
Self-esteem.
Love and self-esteem, yeah, I think that's
Okay.
more
I thought
appropriate.
sexuality because his body was changing. His body has tears in it.
What about activity?
I think we have it under, well, how's it going to affect activity?
Like if it's a dog, we can't move it as much, or even with the.
So you're saying that maybe the pain would cause him not to move as much? So it's under the pain, so you want to put it under the activity also?
Well, would it be enough to just be under the pain?
Is it?
I think. I know.
Defend it, go ahead.
No,
I'm not
if-
saying it's right or wrong, but I
no,
want
I'm
you to
saying
defend
if
it.
if
Justify it.
your bottom hurts or whatever, and then your elbows hurt, you're not gonna move as much because you don't want it to
Hurt
touch
anymore.
like the reddened areas or whatever. or-
Then linen.
You
Yeah,
justified
worse.
it? Good, good, very good. So we can put it up here, skin, breakdown. I have one more spot that you guys are missing.
How about fluids, nutrition? No.
O2.
Oh,
Okay.
too.
You got a
O2,
break in the
right.
skin, the perfusion's changing,
Oh,
okay?
I didn't know that one.
Now, talk to me about nutrition. How are my skin tears and skin redness going to affect my intake?
I know you need your protein and stuff to
To heal.
better. Plus, he's a diabetic,
Right.
so it's gonna take forever. To
So my skin, this patient's skin issues are affecting nutrition because they have to increase their intake. It's not that the nutrition, the skin tears aren't going to change
No.
the nutrition.
Just need better
You
nutrition.
need
Or
better.
diet nutrition.
Better.
Better.
Yeah, I would stick to interventions for that one.
Okay.
Okay, I think we have it everywhere. What's our next data piece?
He spends the wheelchair.
He's in a wheelchair. We'll abbreviate that W-C. Where's that going to go?
Activity.
activity. Yeah.
Okay. I hear the prevention from harm. Why?
From harm.
You could fall.
Coming.
So you won't walk, so he's in a
Going on the
wheelchair.
wheelchair or off of it, you can get hurt, you can slip.
Sure,
Right off the
sure,
wheelchair.
So
sure. He's
safety,
not
yeah.
running the halls. Activity, because he's not running the halls. So WC. Anywhere else?
Love and self-esteem.
Okay.
Yeah.
Is it going to affect elimination, maybe?
Yeah.
Yeah.
You're
He's
sitting.
not going to be able to jump out of bed and
hide
go
from
into the bathroom. He's going to have to call someone. Okay. What's the next?
Physical
Therapy.
therapy.
Yep.
Okay.
That's like.
And we have occupational therapy too?
Yeah.
I'm going to stick that over here and we're going to plot them in. Can anyone tell me what physical therapy is? I'm trying to find out the difference between the two so that we can put them appropriately in our,
Physical therapy helps them move around, like they do their ROs and walk up and down the hallway, see what they can and can't do.
strengthening,
Yeah.
balance, teaching how to walk with apparatuses, whether, he walks with a quad cane. That's physical therapy's domain. What does occupational therapy do?
What they can
To acquire, so you can do
on their own.
Activities of daily
They
living.
can do on their own.
You're going to bring them into the bathroom, help them wash up, show them how to manipulate in their environment with their disabilities,
Right.
whether that's teaching them how to cook, teaching them how to use a refrigerator from a wheelchair, or maybe making special spoons
Yeah.
that have straps on them, or special cup holders. Okay, that's occupational therapy. So let's take them individually. They do overlap, and we're going to plot them in, and they're going, sometimes occupational therapy and physical therapy are going to go hand in hand together, but let's plot them in one at a time. Let's take physical therapy first.
Physical therapy.
Activity.
Activity, yes.
PT.
Where else is PT going to go? Why love and self-esteem? You're right.
He's getting self-esteem back. He's going to get the strength to get up and want to do it.
Right, he's not mobile right now. So it's affecting his self-esteem, and hopefully physical therapy will help
Yeah.
give him that independence. Anywhere else?
Prevention from harm.
Why?
Trying to show him how to get back his strength.
Yeah, the balance and the strength.
Mm-hmm.
Oxygen, I heard.
to get his circulation
Back, yeah.
back.
Yeah,
Yeah.
I think we can go there. Okay. Anywhere else? Let's look at occupational therapy, and maybe we'll find other places physical therapy goes. Occupational therapy, where are we going to go?
Fluid and nutrition.
Fluid and nutrition, is that going to go? Physical therapy is not going to, it's not physical therapy's domain. Although, let me tell you, when you're out there in the real world, sometimes they only have physical therapy, so then it does become physical therapy's domain, occupational therapy. They will take on some of those responsibilities, not showing them how to bathe and stuff, but I'm talking about making the appliances to eat with. They'll take over that. So let's just, for our purposes, since we have both, let's put it in fluids and nutrition. Where else?
Activity.
Activity.
Elimination, because they're going to help them in the bathroom.
Bathroom.
Yep. What about asepsis, guys?
Yeah.
What are they doing with
Teaching
them?
them how to clean and use good
Yeah.
hygiene.
Okay, so prevention from harm.
Yeah.
OT?
Yep.
Sure, they're going to teach them how to maneuver in their environment.
Get the love and self-esteem back. They're starting to do their everyday ADLs.
Absolutely, you're thinking, guys, you're thinking. O2, occupational therapy? Nah.
No.
You don't think so?
Fluids and nutrition, do you want to make a case for it? Because we can.
No.
No? Because, I mean, we can probably figure out a way to put it in there. Might take a while. It's already elimination. How about activity?
Yes.
Yeah. I think that's probably the way to go. That's probably it. Okay, so I can take it out of my little middle list here. All right, next piece of data.
Here's the
The quad cane.
Okay. Can we take the whole piece of ambulating with the quad cane 100 feet with assistance.
Yeah.
Where does that whole piece go? Because then we're going to break it off. Activity. We're all happy that the whole piece goes in activity, because then we're going to break it off, and because there's some things that go some places and others. So ambulates 100 feet with, C with the line over it means with, a quad cane, and 1 assist. Okay? That's all in activity. Is the ambulating 100 feet going to go anywhere else?
Yeah, because by him ambulating and walking 100 feet is also showing some kind of PT, prevention from harm, because he's kind of doing it.
Okay, but what piece of that, what piece?
Getting up, moving around,
The one
strengthening.
assist.
If he's walking, his circulation is gonna be.
Moving around.
Okay, well, let's stick with prevention from harm and see what, if the ambulate 100 feet, quad cane, and assistive 1, are they all going to go into prevention from harm?
Because he
The one
ambulated with the
assist.
quad cane.
The one assist is gonna go prevention of.
Goes in prevention from harm? Okay, so 1 assist. How about the quad cane?
Okay,
Yeah, because it helps
Yeah.
him.
Yeah, quad cane does. I don't think that the ambulating,
Okay.
but I heard oxygen for the ambulating.
Right.
I agree with that.
Yeah.
Yeah.
Well, we know he requires oxygen.
Okay, let me put that in the middle. We'll get back to it.
It's on there.
Yep. What about in love and self-esteem? What pieces might go in there?
Quad cane.
100 feet, why? The ambulating the 100 feet?
Because he might do 102 the next day, and then 200 the next day.
Yes, yes. So ambulate 100 feet is a positive for our patient, gives a place to start, and hopefully will increase our self-esteem as we increase our ambulation. Could work both ways. What about the quad cane? Is that going to go up there?
Yes.
Why? What's that going to do to self-esteem?
Right.
Like,
So they're going in there for different reasons, but they're still appropriate. So I'm going to put quad cane and 1 assist in there. Asepsis goes into sepsis? Nah. We've got in prevention from harm. We've got it in O2. Fluids and nutrition? No. Elimination?
He's up.
What parts of it? So what parts of it are going to go in elimination?
Ambulate, 1 assist.
Even the quad can go.
Okay, so how about we do 1 assist in the quad cane?
Yeah.
Do we need to have the 100 feet in there?
no.
Okay. Because they're going to need
An assist.
they're going to need a person when they get out of bed. They're going to need that person to help them get to the bathroom, and they're going to need that quad cane. That's why I kind of
Assist
kept
with
the.
cane. Yeah.
Okay, is that everywhere it goes? Isn't that just about everywhere it goes? Okay, what's our next piece of data? You guys are doing good.
Sacral area,
sacral
left
area.
elbows have recently become reddened.
Okay, but we did that all in skin.
Skin,
Remember
yeah.
we did that in
Skin
skin?
breakdown,
Okay,
yeah.
so we've done that. Yes, yeah.
Yeah, aspiration.
Okay, remains in the periphery means, okay, we have a whole group of students right here. One student is over here sitting, okay? This student is on the periphery, not part of the group in the room and area, yes, thank you, but outside of the group, that's on the periphery. So where do we want to put that while we were talking about it?
Prevention of harm. Prevention from harm.
Well, is it a prevention from harm issue? you
Activity.
think?
Love and self-esteem.
Yeah, it's a love and self-esteem. They're on the outside. So I'm just going to put on the periphery. And we'll remember what that means. Okay, what's next?
Activity.
Suffer from aspiration and pneumonia.
Okay, we've dealt with the aspiration. We've got the aspiration precautions here. We don't have the aspiration up here. Pneumonia, let's put that up here.
Okay.
Oops. And can we deal with the O2 while we're up here in
Yeah.
oxygen? That's going to go up in oxygen, the O2?
Yeah.
Okay, O2, 2 liters. NC is nasal cannula. Is that going to go anywhere else? Nasal cannula. It's a way of delivering the oxygen in the nose.
Love and self-esteem.
Yes,
Hard to
exactly.
sleep with.
Hard to sleep with?
Yeah.
So the nasal cannula
Yeah, sometimes it drives you out, yeah, and it's stuck to the wall.
is giving oxygen noisy.
Yeah, it's out.
Okay, so I'm going to put the O2 there also just because of the noise factor. Yes, ma'am.
Love and self-esteem,
Why?
because it's kind of embarrassing to.
So we're going to talk about the nasal
have
cannula.
Cannula itself.
Okay, so I'm going to put
For the tank.
NC over here. Anywhere else? We going?
Would it be under activity? Just like when he's ambulating, keeping that in mind that he is on oxygen and you have to.
So
limit-
it's going to affect the way that we ambulate him. We might need another person
Right.
to ambulate him. So we'll just put the O2. We need to make sure we have that with him.
What about prevention from harm?
What piece of it? All of it? A piece of it? O2 nasal cannula?
They always pulling it in and out because they don't like it. So
Tries out there now.
We don't know that he is,
Yeah.
but
you know
but
that he might.
he's going to have tubing that he can trip over. He's going to have oxygen that he's going to need to have on to prevent him from having breathing difficulties or dropping his oxygenation. So I'm not saying it's not. It is. Okay? So O2 and the nasal cannula. What about skin breakdown around where that,
Oh, the area,
Yeah.
the redness there.
okay? If
And
if
even
he
the
was
nose.
having that problem, we could,
Sepsis.
he's got the potential for that happening because he has areas of skin breakdown to start with. Okay, so we want to make sure that we address that. Okay, so we dealt with the O2. I can take that out of my little pile here in the middle. What else?
Bowel is okay. It's okay. It's 3 times every
Every
3.
three
Oh, every 3 days.
Oh,
Yeah,
that's too
elimination.
much.
Okay,
Elimination.
it's going to go under elimination?
Yeah.
Okay, BM. Q is every
Every.
3 days with meds. Now, if we knew what the meds were,
Oh,
we
with
would,
assistance of medication.
yep. If we knew what the medications were, where would we put them? Under elimination. Milk of mag, the evening before, Fleet's enema in the morning, Colace every day. You'd put them all in to that elimination, as they all affect elimination.
Would
Okay?
he be in pain too if he doesn't go 3 days?
He could. Do we know it though? It potentially could happen. It potentially could go there if there is that issue. Yep. Do you guys want to put it there? BMQ 3 days?
Well, yeah, because we want to avoid it.
Pain.
Pain.
We want to avoid it, so we put it in elimination because it affects elimination. I mean, you could always add it after the fact if you had that. Okay? Are we up to urinary incontinence? Is that the last
Yeah.
piece? We're in the last piece. Okay, I'm going to take urinary incontinence at night off, and where are we going with it? Where are we
So
plotting
rest
it?
and sleep.
Rest and sleep, why?
He needs his urinal at his bedside. If it's not there, he can't go. It's but he goes and it be incontinent and wet. It's cold.
And so what are you going to have to do to him?
Put the urinal at his bedside for him.
And if he gets incontinent, what are you going to have to do?
Change him.
Change him. Yeah, so it's going to affect sleep. Part of our interventions, if we did that as a problem, would be to make sure that urinal is at the bedside. Where else are we going to put it?
Sepsis.
Asepsis, why?
Because it's you can have breakdown with the urine on your bottom.
Yeah, we already have skin breakdown. If we don't get him clean, we're potentially going to have it worse.
Self-esteem.
Love and self-esteem, yes. Anywhere else? What if he tries to get out of bed to get that urinal?
You can fall, prevent you from harm.
Yep. And just the fact that he's incontinent if that urinal's not there kind of sets the tone that yes, it goes under prevention from harm.
Yeah.
Anywhere else are we going with it? Okay, is that the last piece of information? We might find some along the way when we start doing the actual care plans. Everyone feel kind of comfortable with this? We're going to visit it every week. So make sure you put it in a folder. Make sure when you think about plotting these in, say to yourself, well, how does that thickened liquids affect elimination? How does that thickened liquids affect fluids and nutrition? Okay? Say that in your mind. How is it going to affect pain avoidance? And you're like, it's not going to affect. Having thickened liquids is not going to affect pain avoidance, so it wouldn't be plotted in there. So say that in your mind as you're trying to figure out where to plot these specific items of data. Okay? Everyone all right?
Yes.
Okay. Next week we'll do nursing diagnoses from what you've got there.
Okay.
Okay, and I'll give you care plans and everything. So buy yourself a folder and stick the stuff in.
Fix it first.
Have a good day.